So, good evening to all, and welcome to this lecture series on pharmacy practice. This is Dr.Sourabh Kosey, Professor and Head, Pharmacy Practice, ISFCP Moga. My sincere gratitude and acknowledgement to the management, director sir, principal sir, HODs, faculty members, and all the participants joining this YouTube live on lecture number 5 of B.Pharm 7 semester pharmacy practice syllabus. Drug-drug interaction. So drug-drug interaction is typically when there are prescriptions in OPD or patients in IPD having drugs or medicines. They tends to react to each other. So when the drugs with taken alongside may have a tendency to alter each other action is called as drug-drug interaction. So medicines can be taken with water, can be with food, fruits, and together, all together. So it's a nature's law, food and drugs we take from outside the body to inside the body, from external environment to the internal environment. Whereas food, fruits, water, oxygen is hibernated, you are respirating. So drug interaction, what is the definition? It may be an action or interaction of one medicine with other medicine or one food with disease state. So drug-drug interaction or drug-disease interaction. In the clinical scenario, patients with renal impairment problems, merging alcoholic beverages, or receiving high doses therapy may have metabolic problems. So sometimes pharmacodynamics is also the reason. Sometimes pharmacokinetics, body's response. So we can do the dose titration without increased toxicity. So there are consequence-wise couple of reactions, beneficial, non-beneficial, or adverse reactions. So if we go with the pharmacological class activity, when one molecule is making effect to the other molecule, so that drug is affected by such an interaction is called as object drug. Where the agent or the other drugs which precipitate such as with an interaction is referred to as precipitant. So object drug and precipitant drug. So major drug-drug interactions takes place where the object and the precipitant drugs in the same prescriptions and changes the action of each other due to the chemical incompatibility, physical incompatibility, and its pre-formulation data or specifically the pharmacokinetic or dynamic characteristics is also one of the major factor in which the absorption, distribution, metabolism, and excretion of a molecule is a factor. So the drug whose activity is affected by such as interaction is called as object drug, whereas the agent which precipitates such as interaction refers to the precipitant drug. So one basic concept is clear. The one drug is precipitating drug and the other drug is object drug. So precipitating drugs which are highly bound to plasma protein used for long terms, enzyme inducers or inhibitors, which two drugs simultaneously given for same disease. And the object drugs which have narrow therapeutic index, zero order kinetics, steep dose response curves. So drug-drug interaction, drug-food interactions, drug-disease interaction, drug laboratory test interaction, chemical drug interactions. So harmful, beneficial, quantitative, qualitative, in vitro, in vivo, this all are the parameters of the concerns. So in the today's scenario where we are looking in our life for the effectivity of drug interaction, major organs which are affected are liver, kidney, and due to which our pharmacists are also affected. So one major concern which comes up at the part is to look after such kind of activity where the drug interactions takes place. So drug interaction is something at a point of care level, we need to understand its ideology. And particularly one more thing we need to idealize over here, which is that somebody who is taking the medicines are more in danger if it is not incompatible inside the body. So the concept of compatibility, the concept of reliability, the concept of awareness is one of the major factor where when we compare with the drug compatibility, which each other it is foremost important. So once this is not understood that molecules should be in the proportion of energy. So any kinetic action, any dynamic action, any chemical interaction, any laboratory interactions are one of the concerns. So in particular, we need to check out, we need to see that the molecules which we are looking for is the molecule should be safe, non-toxic, efficacious, having particularly less side effects, adverse effects. So this is our reason why we are why we are understanding that whensoever the molecule is being used at disease level, at laboratory level, at chemical level, at food level, should be safe enough. So mostly desirable, undesirable, beneficial and harmful kind of interactions takes place. Like if I talk about the beneficials, like enhancement of activity of penicillin when administered with probenecid. So in this case, the activity is enhanced. So sometimes additive effects are particularly calculated. So if I talk about the mechanism of drug interactions, pharmaceutical interactions, pharmacokinetic interactions, pharmacodynamic interactions are along with. The reason particularly of this pharmacokinetic and pharmacodynamic interactions or pharmaceutical interactions is to understand that what level of property and the problem may occur in particular with this kind of medication. So what happens whenever we are consuming or administering any molecule, we need to understand that particularly our body and our drug and its property are the main reason for the purpose. So once you are particularly done with a visit to a physician, the physician wrote a prescription and a bit in a hurry due to more number of patient pool, there are less chances that physician will give equivalent time and focus on each and every patient. So in that case, sometime unintentionally, the medicines are being written in a coordinated way. Unintentionally, sometimes it has a loss. So what I understand here is in which the pharmacokinetic concerns, pharmacokinetic interactions. So the basic principle, absorption, distribution, metabolism, and excretions comes, and wheresoever we understand that the particular case ADME, absorption, distribution, metabolism, and in this the object drug is altered by the precipitant, and hence such interactions are also called as ADME interactions. And the resultant effect is altered plasma concentration of the object drug. So understanding one law of nature is a particular setup, and in this particular setup we need to understand pharmacokinetic interactions are of absorption, distribution interactions, metabolism interactions, excretion. So absorption interactions are those where the absorption of the object drugs is altered. And the net effect of such interaction is faster or slower drug absorption, whereas more or less complete drug absorption takes place. And the major mechanism in the absorption interactions are complexation, adsorption, alteration in GI-pH, alteration in gut motility, inhibition of GI enzymes, alteration of GI microflora, malabsorption syndrome. So the typical setup of a drug interaction is with the drugs, with the food, with the supplements or the medical condition which is related with the serious adverse event or some nutraceuticals or some specific foods, and the possible effects is delayed action or enhanced in action or resulting in the serious adverse effects. And that is what is particularly a one concern where the problem arises. Okay. So where I see drug food and drug herb may enhance or delay the actions with adverse effects or with neutral effect or nocebo or no effect. So pharmacokinetic, pharmacodynamic interactions, interactions, clinical interactions. When we go to ward round and collect the case, from that case collection, post case collection, you have a certain kind of case where 6 or 7 molecules are written by a prescriber or clinician or physician to patient. So the moment you come from the ward round and enters into the drug information center or information technology lab with ultra speed internet and monitor, you need to particularly set check that medscape.org, what are the compatibility of these medicines with each other, with pharmacokinetic interactions, dynamic interactions, clinical relevance, clinical significance, managing. So once you are doing the clinical case presentations, at particular pharmacist interventions come, which molecule to be given with which food, drug, or altogether, or to avoid. So that comes. So it interacts with each other, interacts with alcoholic beverages, drug interacts with food items, fruits, herbs. So, in my view, in my knowledge, this drug, which is administered orally, may affect brain, may affect cardiac cavity, may affect renal cavity, may affect various organ systems of the body, which increases the vitality, severity, or vitality risk of adverse effects increases, and the serum sometime concentration also decreases. So in the effects of this metabolism and therapeutic outcome, various inhibitor enzymes, therapeutic outcomes, genetic polymorphisms takes place. What happens in the body when the drug-drug interactions takes place? Altered metabolism, adverse reactions takes place, increased toxicity, sometimes reduced efficacy, compromised drug clearance also takes place, and which are an essential drug or herb interaction such as methotrexates blocks folic acid. So folic acid is required for iron supplementation in the body. Then furosemide, the brand names is Lasix. So this is potassium wasting minor serum potassium level is decreased due to it. Then propofol, exogenous OA-based lipid emulsion provide 1.1 of calcium per ml. Phenantine dilantin is the brand name. Tube feeding decreases, etc. So when this concentrations comes up, where the drug-drug interactions is running up, and this alteration, which combinations which should not be given altogether need to be increased. So drug interactions checkers on the online or Stockley's drug interaction as a reference compendia is available. So drug or drug food interaction or drug disease to be avoided in certain circumstances or situations or conditions. We are in a plus point that if suppose this effects is happening, so we should understand that we should avoid this one. So drug interaction, drug food, drug herb, drug disease, drug allergy interaction, and sometime with the genes also it may affect. So genotoxicity of ICH-S2 guidelines have been given, and international classification of disease, Ayush or herbal pharmacopoeia, and sometimes this allergy is anaphylactic reaction of adverse drug reactions. Foods like mushroom poisoning, sometimes or and many more foods and drugs having properties. And what are the various tips given by the consultants or the physicians to avoid such interactions is maintain and update medicine list. You should have the list and the supplements and herbs that which medicines are particularly having the problems. Then consult with the healthcare provider before you start any new molecule along with the ongoing therapy. Use with the clinical pharmacist, hospital, or the community pharmacist for all the prescriptions. Be cautious with the supplements. Utilize drug interaction checkers online. Read medication labels thoroughly, and avoid grape fruit juice with alcohol. And this can interfere with how medicines work, affecting their effectivity. Some of the common food drug interactions like calcium and antibiotics. So antibiotics such as tetracycline, you might have heard that tetracycline should not be given with the milk because it creates chelations. So it interact with the dairy products and like milk, yogurt, cheese, and the body is then unavailable or unable to effectively absorb the antibiotic as a result of calcium content. Then tyramine and MAO inhibitors. Tyramine can be found in pickled, cured, and fermented foods. If taken with MAO inhibitors, it can lead to previously high blood pressure. So vitamin K and warfarin. Vitamin K is found in green leafy vegetables such as spinach, kale, and broccoli. It's given that warfarin works to inhibit the action of vitamin K, and these patients must be counseled to avoid overconsumption of this vitamin-rich foods. Alcohol and stimulants, so this should be avoided with stimulant drugs because some drugs react worse than others. Taking alcohol with stimulants can lead to erratic and dangerous behavior. And because medicated alcohol like ethanol and methyl alcohol are mixed up in the molecules in a very low quantity scientifically as per the GMP. So grapefruit juice and statins such as atorva, statin, Lipitor, which is a blockbuster drug in world, the most selling drug in the world, should be not be consumed with grapefruit juice, as the juice contains furanocoumarine compounds that increases the drug's potency, which may lead to a condition called rhabdomyolysis. So what are the most common drug interactions? I told vitamin K, calcium, magnesium. Magnesium prevents proper absorption of antibiotics such as tetracycline. Then the iron, antacids such as omeprazole can prevent proper absorption of iron. Vitamin E increases blood thinning effect of anticoagulants such as warfarin. St. John's wort, herbs used for depression, can interact with other antidepressants. Omega 3 may increase blood thinning effects of anticoagulants. Vitamin C, high doses of vitamin C may reduce the effectiveness of some chemotherapy. Zinc, long-term use of diuretics with zinc can lower levels of zinc in the body. Melatonin, which can cause excessive sedation when taken with sleep sedative and hypnotics. Folic acid can reduce the effectiveness of methotrexate when taken altogether. Vitamin D, long-term use of oral steroids such as this can reduce absorption of vitamin D. Ginseng may cause excessively low blood sugar with diabetes medications. Coenzyme Q10 may cause excessively blood pressure when used with blood pressure medications. Fiber can prevent absorption of other medications such as digoxin. So, drug-drug interaction should be a healthy and the beneficial one, but not harmful. And when these interactions, when one drug affects the activity of another, called drug interaction, and this may increase, decrease, or either create an adverse effect. So, pharmacokinetic, ADME, and dynamic, additive, synergistic, or antagonism. So common drug another examples are warfarin and aspirin. So bleeding risk, and it's a pharmacodynamic additive. Then metoprolol and verapamil, it is pharmacodynamic one, causes bradycardia. And then rifampicin, particularly oral contraceptive, may causes contraceptive effect. Then NSAIDs and AC inhibitors, which is causing the digoxin toxicity, antihypertensive effect. Digoxin amiodarone, severe hypotension and digoxin toxicity. Sildenafil and nitrates, severe hypotension, pharmacodynamic activity. Then clarithromycin, simvastatin, pharmacodynamic rhabdomyolysis risk. Then carbamazepine, phenytoin, unpredictable blood levels, and serotonin syndrome risk. Then MAO inhibitors and SSRIs, pharmacodynamic level 1, theophylline toxicity. So this is what is particularly written. Aspirin and warfarin increases the bleeding risk, and NSAIDs and hypertensives, it's reduced hypertension. Then metformin, iodinated constant, lactic acidosis, etc. Ciprofloxacin and theophylline creates theophylline toxicity. AC inhibitors plus potassium supplements are on risk for hyperkalemia risk. Statins and macrolide antibiotics leads to muscle injury or rhabdomyolysis. Antacids and iron supplements reduced iron absorption. SSRIs plus MOIs mouse risk of serotonin syndrome. Diuretics plus digoxin increased digoxin toxicity. Alcohol plus metronidazole, severe nausea and vomiting like disulfiram-like reactions takes place. So whensoever you feels that the drug has been interacted, you need to check the labels of the drugs, and that label you should read carefully. The instructions given by the healthcare provider for you, and use in the Medscape drug interaction channel. There should be common awareness about this drug interaction and keep that list. So what happens when you mix this drugs all together is absorption, distribution, metabolism all are affected. So likewise, like digoxin, vitamin D, neomycin, in distribution interactions, anticoagulants, phenylbutazone, chloral hydrate, increased clotting time, tolbutamide, sulfonamides, increased hypoglycemic effect. Metabolism interactions are those where metabolism of the object drugs is altered, and the mechanisms of metabolism interaction includes enzyme induction, increased rate of metabolism, enzyme inhibition, decreased rate of metabolism. So it is most significant interaction in comparison to other interaction that can be fatal. So metabolism interactions like corticosteroids, barbiturates may decrease plasma level and decreased efficacy of the object drugs. Then oral contraceptives, oral hypoglycemics with rifampicin decreased plasma level. Tyramine-rich food, MAO inhibitors, coumarins, metronidazole, phenylbutazone, increased anticoagulant activity, alcohol and metronidazole, increase in plasma acetaldehyde levels. Then excretion interactions are these where the excretion pattern of the object drug is altered. Major mechanisms of excretion interaction are alteration in renal blood flow, alteration of urine pH, competition for active secretions, and forced diuresis. Then excretion interaction, penicillin, probenecid, elevated plasma level in phagocytic drugs, amphetamine, antacids, thiazides, cetazolamide, increased passive responsibility of basic drugs, increased risk of toxicity. Lithium bicarbonates with NSAIDs, decreased renal clearance of, whereas these are the examples of changes in renal blood flow, and the earlier amphetamine and antacid was change in the urine pH. So pharmacodynamic interactions where synergism or antagonism takes place, in which place similar or opposing pharmacological effects, and antagonism is particularly the interacting drugs have opposing actions. Examples: acetylcholine and noradrenaline have opposite effects on the heart rate. Addition or summation, the interacting drugs have similar actions, and the resultant effect is the sum of the individual drug responses. Like, for an example, CNS depressants like sedatives and hypnotics. Synergism or potentiation. So this is an enhancement of action of one drug by another. Example: alcohol enhances the analgesic activity of aspirin. So indirect pharmacodynamic effects are there. What are the reducing the risk of drug interactions? We need to develop, see the development of negativity in the patients. So risk factors identification, thorough sociodynamic status, family, social status, past medical medication history, drug history should be taken, medical history properly, and be knowledge about the. We should be knowledgeable about the actions of the drugs being used. Consider the therapeutic alterations in case if it is possible to stop or reduce these drug interactions. Avoid complex therapeutic regimens when possible. Education the patient and monitor the therapy. So influence of smoking on drug interaction. In smoking increases the activity of drug metabolizing enzymes in the liver, which result the certain therapeutic agents like diazepam, propoxyphene, theophylline, olanzapine. These are metabolized more rapidly and their effect is decreased. So influence of alcohol on drug interactions, like chronic use of alcoholic beverages may increases the rate of metabolism of drugs such as warfarin and phenytoin, probably by increasing the activity of hepatic enzymes. Acute use of alcohol by non-alcoholic and individuals may cause an inhibition of hepatic enzymes. Influence of food on drug interactions, like food affects the rate and extent of absorption of drugs from GI tract. Example: many antibiotics should be given at least one before or two, an hour or 2 hour after meals to achieve optimal absorption. The type of food may be important with regard to absorption of concurrently administered drugs. And for example, is dietary items such as milk, other dairy products that contain calcium may be decreased. And the absorption of tetracycline and fluoroquinolones derivatives dyes also may influence urinary pH values. So some facts, like most undesirable or harmful, rarely desirable or intentional, like beneficial examples are levodopa plus carbidopa, adrenaline plus lignocaine, sulfamethoxazole plus trimethoprim, penicillin plus probenecid, antibiotics, anti-TB, anti-HIV, anti-leprosy, anti-hypertensive, anti-H. pylori drugs. The net effects of the drug interactions is generally quantitative and seldom qualitative. So increased or decreased action, or seldom qualitative, is a rapid or slow effect precipitation of newer or increased adverse effects. So in a case of this thiopentane on pentone and succinylcholine, and where the pre-formulation and the in vivo, like pH, complexation, chelation, bacterial flora, and mucosal damage also takes place, like altered pH example, which absorption, GIT absorption, antacids plus ketoconazole, where the antacids decreases the tablet dissolution of ketoconazole, which is H2 antagonist. Therefore, this drug should not be given at least 2 hours in the time of administration of both. Metoclopramide plus cyclosporin, where the anti-emetic increases the toxicity, increases the absorption of cyclosporin due to cyclosporin to the increase in the stomach hunting time. Complexation or chelation, tetracycline interacts with the calcium ions and unabsorbable complex occur where the antacid and the ciprofloxacin. Aluminium or magnesium hydroxide of antacid decreased absorption of ciprofloxacin. Digoxin, 40% or more of administered digoxin dose is metabolized by the intestinal flora. Antibiotics kills a large number of normal flora of the intestine, increase digoxin concentration and increase its toxicity. Anti-neoplastic agents plus digoxin, cyclophosphamide, vincristine, procarbazepine inhibits absorptions of several drugs, example digoxin. Pharmacokinetic interactions, distributions like display protein binding, it depends on the affinity of the drugs to plasma protein. The most likely bound drugs is capable to displace others. Like highly bound to plasma protein is phenantine, tolbutamide, warfarin. Drugs that get displaced are aspirin, sulfonamides, phenylbutazine. So the fee drugs is increased by displacement by another drug with higher affinity. Pharmacokinetic interactions where the metabolism comes in enzyme induction, like drug may induce the enzyme. This is responsible for the metabolism, like carbamazepine, antiepileptic increases its own metabolism. Phenantine plus theophylline increases hepatic metabolism of theophylline, which leading to decreased level of its action. And in enzyme inhibition, various other example like verapamil, erythromycin plus estamazole, which inhibit metabolism. Erythromycin inhibit the metabolism of estamazole, and this terfina D increases the serum concentration of antihistaminic, leading to increasing in the life-threatening cardio collapse. Omeprazole and omeprazole inhibits oxidative metabolism of diazepam, active tubular secretion, passive tubular secretions, you told. Pharmacodynamic interactions like additive effect, synergistic effect, antagonism, and potentiation effect. So it means alteration of this drug's action without change in its serum concentration by pharmacokinetic factors. So 1 plus 1 equals to 2, like aspirin plus paracetamol, ibuprofen plus paracetamol. 1 plus 1 equal to less than 2, procaine plus adrenaline, aspirin plus codeine. 1 plus 0 equal to 2, like levodopa, carbidopa, amoxicillin, and clavulanic acid. And 1 plus 1, 0 is pharmacodynamic interactions receptors, like acetylcholine plus atropine, noradrenaline plus, which is competitive or reversible antagonism, where non-competitive or irreversible antagonism, acetylcholine and diamethonium. Noradrenaline plus phenoxybenzyamine. So in this pharmacodynamic interactions, AC inhibitors, ARBs plus NSAIDs, glyceryl nitrates plus sildenafil, calcium channel blockers plus beta blockers, and they have a lot of activities like loss of anti-hypertensive effect, severe hypotension, bradycardia, aminophylline plus salbutamol, dysarrhythmia, loop diuretics plus ethacrynic acid, ototoxicity, propanol plus insulin potentiate hypoglycemia. So drug-drug interaction, major I told, moderate, minor, haloperidol plus phenidine, etc. So some major drug-drug interactions like the development of pseudotumor cerebri, benign intracranial hypertension associated with the concurrent use of isotretinoin and minocycline, tetracyclines. This manufacturers of isotretinoin contraindicates its use with the tetracycline symptoms of intracranial hypertension. Methotrexate and trimethoprim. This interact leads to increased risk of hematological toxicity. Clarithromycin and simvastatin, this black dot interacts particularly to increase risk of myopathy. This is a result of macrolide antibiotics, significantly increases the level of statins. So it is recommended that simvastatin in particular should be stopped during short course of electrolytes. And in this particular regard, we need to understand that if certainly this thing is happening, we need to understand one point, that our level where we are not having that molecule of concern, we should avoid using it altogether. Nurses and clopidogrel, the concurrent use of clopidogrel with naproxen and celecoxib increase the risk of fecal blood loss, gastrointestinal hemorrhage, other bleeding. Manufacturer advise caution if nurses and clopidogrel are given together. Recommend gastrointestinal prophylaxis such as proton pump inhibitor in patients at risk of GI ulceration and bleeding. Digoxin and furosemide, the use of digoxin and loop diuretics, particularly, we need to understand this thing, the digoxin and furosemide, that possibly lead to hypokalemia, which in turn increases the risk of digoxin. Potassium level should be routinely monitored during this therapy. So, particularly going with the this center of the presentation where we gone with this drug interactions. So it is drug interactions where the effects are maybe with the food, maybe with the drink, maybe with the pharmacogenetics, and the various reasons in absorption mechanisms, as you have seen, changes in the pH, bacterial flora, GI mortality, etc. And also antacid, ciprofloxacin, altered pH, altered bacterial flora, erythromycin and digoxin, uh, formation of formation of particularly insoluble complex. So certainly, like you can see, formation of insoluble complexes of tetracycline and quinolones, altered GIT mortality like prokinetics interactions, distribution interactions like warfarin and phenantine. So low volume of distribution, then metabolism, particularly phase 1 modification or conjugation reactions into which cytochrome 4p450 reactions with the parent drug execution, and phase 2 reactions. So pathways of the drug metabolisms takes place into which enzyme inhibition, excretion, pharmacodynamic interaction, herbal drug interaction, food interactions. Who are the patients who are more at risk in this context are particularly patients in high risk of drug interactions, polypharmacy, older people's, because the person who are aged into are having more problems in the body, they are taking more medications. So polypharmacy may occur, hepatic disorders, genetic disorders. And how to handle these drug interactions, particularly you need to check online on to the drug interaction checker on medscape.org. Stock-based drug interaction you can go. You can also check on the applications also, and you can put a list of the major drug interactions. So this is in the drug interactions where the short answer questions from this lecture which can be coming is: define drug interaction, explain the reasons, add a node on idiosyncrasy, add a node on secondary pharmacological effects, add a node on pharmacokinetic drug interaction, add a node on allergic drug reactions, and particularly short answer questions, define adverse drug reactions, classify ideas. What do you mean by therapeutic decision making? What do you mean by drug level studies? What is a drug profile record? What is cohort study? What is particularly drug interaction, define anaphylaxis, and in very long questions, explain reporting and management of drug interactions. And another question which may arise is explain the methods used to detection of drug interactions. And the references and the bibliography is a book authored by me, just published by Nirali Prakashan as per syllabus of B.Pharm 7th semester. And particularly, I would like to acknowledge and thank Dr. Abhishek Vijukumar for this YouTube live as IT coordinator in this series. So thank you so much, all of you, for joining on this lecture number 5 of drug interaction. And please comment into the chat box to subscribe to the channel, and let me know if any questions are there via my mail ID saurabhkosey@gmail.com or my WhatsApp number 9501305664, and I will be more than happy to answer it. So thank you so much everyone for your time.